Thank you. There's no doubt that Elsevier has contributed tremendously to the spread of medical knowledge for a long, long time, and certainly has the best journals. And perhaps that's the IT and communication behind Elsevier has certainly helped the medical fraternity, be it and the patients at the end of the day. So now I thank the speakers for having stuck to time. I know that I would like Mr. Anil Swarup also to say a few words, and I think he can do that sitting. Mr. Anil Swarup, your thoughts about whether medical technology or advancements have Indianized enough to change it for the patient. Are we doing enough for the patient welfare, or are we just following the West in terms of technology, diagnostics, and therapeutics?
Thank you very much. A very good afternoon to all of you. First of all, I must explain what is a bureaucrat doing amongst the doctors here. I'm neither a technologist nor a doctor. I don't have any such qualifications to be sitting here and discussing what I've been asked to discuss. But I'll share with you what...
But I will just interrupt. In fact, his views are going to be the most pertinent because they are from a receiver's end and not from a provider's end.
Let me digress a bit and let me share with you what has happened on the technology front in India in delivering healthcare in this country, coming from a man who's in labor, as they say, where we, by definition, cannot deliver much, because if you deliver, you're out of labor. So being in the Ministry of Labor and Employment, when I joined here, I didn't know really what to do. So there was this mandate from the Prime Minister. He said that there should be a health insurance scheme for the poorest of the poor in the country. And the Ministry of Health was asked to do that. They knew that it is a very difficult task. I didn't. So they said no to it. I was pushed into it. So we got into this health insurance. I didn't even know what health insurance was when we started it all. But gradually over a period of time, we've come up with a scheme called, I don't know how many of you have heard of it, because it's not meant for the sexy lot of this country. It is meant for the poorest of the poor, most of whom are in the villages. It's called the Rashtriya Swasthya Bima Yojana. It is the smart card-based, first ever paperless health insurance scheme in the world. And it's doing reasonably well. We've covered about 90 million people. 2 million of those have already gone to the hospital and got benefits. It's now been picked up by UN as one of the top 18 schemes in the world. It got recognition internationally before it got to be known in India. As you know, when yoga becomes yoga, it tends to be recognized in the country of its origin. Gradually, the people in India are also coming to know of this scheme. This basically scheme enables a poor man to visit any empaneled hospital, public or private, anywhere in the country. And when we started this scheme, we looked at the beneficiary very, very closely. And that is something which probably I'll share with you, and all of us should indulge in it. I was so happy that some of the discussion centered around the cost of it. The medical care becoming, as I use the term, commercial in this country, which is very unfortunate. But the true test of what all we will do is whether we make it affordable to those people who are there, who are to use this technology, are benefited through the use of the technology, if the cost can be brought down. And something which we attempted in this scheme. What this scheme actually does is, as I said, an enrolled family which possesses a smart card, this card can be used anywhere in the country in any empaneled hospital. This is perhaps the first ever scheme of the government where benefits can be taken anywhere. Whether it's public distribution system of NREGA, all these benefits are located to a particular delivery point. And in that sense, we believe that the beneficiary stands empowered because he decides the hospital that he wants to visit. It is probably the first ever empowerment of the poorest of the poor in this country because he has a choice. And if he has a choice, he'll decide where he has to go. I think this is also the first ever business model for a social sector scheme. The country has been talking and implementing a large number of social sector schemes. But herein, whereas the funding for the premium comes from the government, its operation actually rests in the hands of the insurance companies, the hospitals. When I went to the Planning Commission with the scheme and I told them there's no targets in the scheme, they actually were shocked because government schemes don't run on non-targets, so to say. And I tried to explain to them, this is a business model in the context that the insurance company gets the premium from us on the basis of the number of smart cards that they issue. So they are incentivized inherently to issue as many smart cards as possible. Similarly, this smart card carries a credit of 30,000 rupees in the chip and all the biometric data of the beneficiaries therein. So when he goes to the hospitals are incentivized to treat him. Of course, there are other associated problems, but we don't have a single case where the hospital has chased away a beneficiary. They welcome them. So the hospital is benefited, the insurance company is benefited, and government benefits because it's put money in the hands of, not money really, entitlement in the hands of the beneficiary, which cannot be misused, basically. And mind you, we use a very, very sophisticated technology. There are 11 sets of software that are making it happen. This is the first ever time that the smart cards are actually printed, personalized in the village and handed over on the spot. It doesn't happen anywhere in the world. Your and mine credit and debit cards are printed elsewhere and delivered to you. In this case, we did want to guarantee that the card gets delivered to the person who this card should go. And mind you, of the 24 million smart cards that are in the field today, not a single smart card has been issued to a wrong person. To make that statement in a country like ours is quite a statement. And this happens because we have a very robust security system where the card cannot be issued to a wrong person because there is an officer sitting there who also has a smart card, has to electronically certify through his own biometric verification that the person standing in front of the laptop is the one whose name is appearing on the laptop. And hence, not a single card has been issued to a wrong person. So the scheme seems to be happening. It's happening in 25 states of the country, length and breadth. The advantage we see here is the appropriate use of technology. And since we've started this scheme, a number of people keep coming me and asking me, how could this technology be taken further? And I'm so glad there was this discussion about the health information system. We have taken in principle a decision to use this chip for the purpose of converting this card into a health card. What we are struggling with now is the issues relating to privacy. What all information can be stored in this card? Who all should be allowed access? Now imagine the strength of this card once this information gets stored, whichever hospital he goes into, without accessing a back-end database system. On the front end itself, they get to know the history of that patient who's coming there. So these are things that can really happen. We can use the technology this way, or we can use the technology to disturb conferences where we can speak on the mobile while the discussion is on. It's a question of how you and I are prepared to use the technology. If we are prepared to use it appropriately, people will benefit. Otherwise, we can use this technology to disrupt the best of discussions. Thank you very much.
That was profound. Can I just ask you, I mean, this is the first time, I've heard of the initiative, but the first time I've been really enamored by the intricacies involved in the perfectness to which it has been executed. So let's go further on that. How, in the 12th five-year plan, where is this going? Is it going to encompass now a national agenda? It'll be in all the districts? Is it actually
I didn't have time, otherwise I would have given you the picture of it. My vision is not only will almost the entire country be covered at some point in time, in next 5 years almost 30 million people will be covered. In next 3 years, sorry. The government is funding the premium for the poorest of the poor. The most interesting development in this scheme is private sector businesses are approaching me to allow this platform to be used by them. They are prepared to pay the entire premium. And on experimental basis, we have given this permission to IFMR Trust, we've given to Manipal Education Society, and very interestingly, the German embassy here. We want to experiment whether people are prepared to pay the premium. Now, when I say it's a business model, they find value in the scheme, and that is why they're prepared to pay the money. If that happens, there's a revolution in the offing. What is also interestingly happening, this is perhaps the first ever government scheme where repeated independent evaluations have revealed that the consumer satisfaction is 70 to 90% for a government scheme. No government scheme has this consumer satisfaction. The first ever revelation was made by Wall Street Journal, who sent a team across to India. And they spoke to me and asked me, how's this scheme? I said, you are asking the wrong man. Go to the field and find it out for yourself. They went and published a report in New York, and the whole world sat up and started looking at the scheme. And then the World Bank called me over to Washington. This scheme is now going to 5 countries already. They have decided to implement this scheme. It's happening thick and fast. And it's not only going to cover here. This is probably a very good example of how IT applications can actually be used to deliver a particular benefit seamlessly. Because this guy who has the card walks in like a king in a hospital, takes his treatment, he hasn't to sign anywhere. It's a paperless scheme. He walks out of the hospital. That's it, period. He doesn't have to do anything. He gets his treatment. And that's why they're satisfied. When I say 70 to 90%, that's the reason. So that is one. Secondly, the government itself is moving gradually up the ladder. The decision has already been taken to extend this scheme to domestic workers, to NREJ beneficiaries as are not BPL, to building and construction workers, to street vendors, and there are about 6 of them are on the annual. Almost everyone is asking me this question, why not this sector? Why not this segment? Rather than asking me, why this scheme?
Great. So I think that while we are at our 3:30, which is our close-up time, it's just fair to actually have a few questions from the audience. 5 minutes is all that it takes, and I think it'd be okay for the audience to be asking the questions. So please go ahead. Please feel free, shoot it at anybody.
Firstly, I must compliment the organizers for getting such a key panel on a single platform. So basically what I understand that questions you have thrown open are pertaining to choice of appropriate technology at an affordable cost with a value for the patient. Now, what pointed questions I have for you all today is, firstly, that why not to use the indigenous technology when there are so many indigenous developments that occurred. For example, see we have a radioclam stent and so many ventilators and so on, but they don't find much favor with Indian doctors. Second issue is of the need-based induction of technology. Why have 100 CT scans on the same street in Delhi when we can develop few centers of excellence? And like these are time-tested models which are used in US called Rochester model, where each one center of excellence is allowed to develop, say one in neurology, one in cardiology, depending upon the need of the community. So that will eliminate cut practice. And lastly, why not share resources? Say we have one gamma knife, let it be shared between Batra Hospital and Max Hospital. It will be optimally utilized just as the way we share the blood banks. So if we share our resources, the laser equipment or more cost-intensive equipment, so the cost will come down, cut practice will be eliminated, and the technology will be used more optimally. So when